I think it's an exciting time that therapies that target so-called gene regulatory mechanisms like Menin inhibitors are really now making it into patients and seem to be making an impact. I'm hopeful that as we continue to learn how all of these mechanisms work, we may be able to come up with other drugs. And then, of course, I think all of our goal is to at some point, like what's the case for acute promyelocytic leukemia, actually get to the point where you don't have to use a chemotherapy. So when we'll get there, who knows? But at least there's hope that, things are progressing.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera. Today we have the pleasure to have with us Dr. Scott Armstrong and Professor Marc Raaijmakers. So first, Dr. Armstrong, can you please introduce yourself?
Yes, my name is Scott Armstrong. I'm at the Dana-Farber Cancer Institute in Boston, Massachusetts. There I am the Chief Research Strategy Officer and the Senior Vice President for Drug Discovery.
Thank you for being with us today. And Professor Raaijmakers, can you please introduce yourself?
Yes, I'm Marc Raaijmakers. I'm a clinical hematologist and the Vice Chair of the Department of Hematology in the Erasmus Medical Center in Rotterdam, the Netherlands. And I'm also the co-chair of HOVON and the HOVON Leukemia Working Group.
We have invited you because you were the speakers this year at the ASH EHA Symposium at the ASH Congress, and we are interested in learning why menin inhibitors are the newest therapeutic option for the treatment of acute myeloid leukemia, which AML patients should benefit from these menin inhibitors, and what the clinical evidence for their use in AML patients is. So first, Dr. Armstrong, the basic question, why are menin inhibitors a therapeutic option for AML?
So menin inhibitors, as they're named, inhibit the function of a protein called menin that binds to DNA and supports the function of critical oncoproteins that drive the development of certain subtypes of AML. And these small molecules inactivate the oncoproteins or bind to menin and inactivate the oncoproteins such that they can no longer drive the gene expression or gene activity that is required to keep the leukemia growing and proliferating. So preclinical work showed that they were very effective in stopping the proliferation and inducing the death of certain types of leukemia cells, and that's what prompted their movement to clinical trials.
So the menin inhibitors are efficient only for a subset of leukemias. Can you explain this, please?
The protein menin was first recognized to be important in a relatively rare subtype of AML that has translocations in a gene called MLL or KMT2A, because the menin protein actually binds to the KMT2A protein. So that was the first subtype of AML that it was recognized that these might work. And then the next subtype is AML with mutations in the nucleophosphamine 1 gene, so-called NPM1 mutations. That's a much more common subtype of AML. And more recently, there are some other, maybe somewhat less common subtypes that look like they might be amenable to treatment as well. But these first two are the ones that are both approved and where there's the most evidence that they could be effective. Those two probably represent somewhere between 30 and 40% of those two subtypes. If you bring in all the others, somewhat rarer subtypes, we're probably talking close to 50%.
So there have been important clinical developments lately. There have been two menin inhibitors accepted, one about a year ago and one really recently. Can you summarize the data on these inhibitors and why they have been approved for use on AML?
Yes, so revumenib and ziftomenib have been approved in the relapsed refractory KMT2A rearranged or NPM1-mutated setting. So this is based on two studies in this relapsed refractory population, the Augment 101 study and the Comet 001 study. So in the Augment 101 study, revumenib was used in NPM1-mutated and KMT2A rearranged acute myeloid leukemia. And that showed responses for the KMT2A rearranged group, so complete remission or complete remission with partial recovery of counts in about 23%. And the overall responses were above 60%. And then for the other subtype, the NPM1-mutated patients, both agents met their primary endpoint, which was CR/CRh. And there again, responses were approximately 23%. So this then eventually led to the FDA approval for revumenib for both NPM1 and KMT2A arranged acute myeloid leukemia, both in pediatric and adult patients. And ziftomenib is approved for the NPM1-mutated AML cases. So that's the data that is quite impressive that led to the approval of these two agents in this particular setting.
So what does the safety and tolerability profile look like for these molecules?
Yeah, so generally these were well tolerated. What was most noticeable and perhaps not unexpected is the occurrence of differentiation syndrome in a significant proportion of patients, mostly grade 3 and manageable, but still an important to be expected adverse event that needs to be managed carefully. And then the other thing was QTc prolongation. This was mostly and most prevalent an adverse event in the revumenib treated patients, and not so much, or at least at less prevalence, in the ziftomenib treated patients. Those were the two, if you would say, adverse events of special interest that emerged in these trials.
So what do you think stands out about these results? Why is there so much interest now in these inhibitors?
Well, so these drugs in the relapse refractory setting were tested in heavily pre-treated patients. So patients where really we have no good options left. So having these response rates, including these overall response rates that actually make a patient amenable to allotransplant, which was possible in a number of patients, is a considerable improvement on what we currently have available. I think that is what is at the ground of the enthusiasm about these Menin inhibitors in the relapse refractory setting.
So at the moment, these two inhibitors are approved by FDA in the US. Are they approved in Europe?
No, they're not approved in Europe yet. I expect that to happen and hopefully next year. So people in Europe would have to wait, although I do think that there is, on basis of clinical need, programs available in at least some European countries. But EMA approval will likely occur somewhere next year.
So, Dr. Armstrong, and there are other ongoing clinical trials for other menin inhibitors. What can you tell us about these?
Yes, so we've talked so far about revumenib and ziftomenib, two that are approved in the United States by the FDA. There are at least 4 more menin inhibitors that are being tested as single agents from different companies as well. They all appear to work very similarly, and so I would imagine that the response rates would be similar. We'll see from those trials. The mechanisms of resistance might be slightly different, so I think there is some possibility that you could use one in a patient, and if that didn't work for that patient, you might be able to use another. Those types of trials are being planned as well. And then there are a number of activities starting and programs starting to look at so-called next-generation menin inhibitors, much like many drugs. There'll be iterations and there'll be a first generation, second generation. So I think those are down the road for sure, but there is some discussion about that as well.
So you touched on the mechanisms of resistance already. So AML often finds a way around these therapies. What are the main mechanisms of resistance that have been observed with menin inhibitors?
Right, so the most recognizable form of resistance is the leukemia will develop a mutation in the binding pocket of menin to where the drug binds, such that the drug now can no longer inhibit the interaction between menin and KMT2A. Very specific amino acid mutations develop, and that occurs in probably, at least there haven't been big studies looking at this, but somewhere on the order of 30 to 40% of patients, when their leukemia progresses, will have these types of mutations. A lot of people looking into how that works and what you might be able to do to either prevent that or treat after those mutations develop. But it certainly is being seen with some frequency.
What strategies are being explored to overcome this?
Much like with any targeted therapy, the combinations are almost always, in any cancer, not just leukemia, are almost always required. And there are a number of clinical trials now ongoing, combining the Menin inhibitors with chemotherapy, other types of therapies. Hopefully at some point we can get to the stage where we're using just targeted therapies, but I think that day's a ways off. But combinations for sure will, if these are going to lead to prolonged survival of patients in the long run, it's going to have to be with combinations for sure.
What are the main side effects that you have observed with menin inhibitors, and how will that influence their use in patients?
As I said, so the main adverse events were differentiation syndrome. They may be common to all menin inhibitors, given the fact that they are differentiating agents, and so to be expected. And then there may be some adverse events that are more specific to certain drugs. I mentioned the QTc prolongation for revumenib in comparison to ziftomenib. Itching has been reported as a manageable adverse event of ziftomenib and more specific for ziftomenib. And then there is myelosuppression that may or may not play a role. I don't think that the data is fully clear yet, but there may be myelosuppression associated with the use of menin inhibitors, and that may vary between compounds. But I think that data is not easy to convey in clinical trials, and we have to see more data to be really more clear on that point, in my opinion.
How crucial is now the molecular testing of AML to ensure that these drugs are the right fit for that patient? Is it available everywhere, the testing for the right mutations?
Yeah, so it's a good point. So if you look at the subtypes that are most susceptible to menin inhibitors, is the NPM1-mutated and KMT2A range. That is standard practice because these genetic abnormalities are part of the genetic risk classification for newly diagnosed AML patients. So I think in most places we would, in a standard fashion, see if a patient has these mutations, but this is at diagnosis. And perhaps we'll speak a little bit about the movement of these therapies to upfront therapy later, but for now they are approved only in a relapse refractory setting. Now these are two mutations that tend to stay there in patients if they relapse, but still I think it would be good practice, now we have these agents available, that if you have a relapse refractory AML patient, to do molecular profiling again. You would do that to see if they have a FLT3 mutation, because there is agents approved in the FLT3 mutated setting in relapse refractory AML, but now then also to know if they have an NPM1 mutation or a KMT2A rearrangement. So I would very much encourage to do molecular workup at relapse for our patients that are amenable to these agents.
In your opinion, how transformative could be menin inhibitors for AML patients?
Now we have been talking relapse refractory, but as Scott was already alluding to, these are powerful agents and we are seeing if we can move them up front. So currently phase 1 clinical trials are being conducted or have been reported where we combine these menin inhibitors with our standard of care upfront therapy, which is Ven/Aza in the elderly or the patients that are not eligible for intensive chemotherapy. And it would be in combination with 3+7 chemotherapy for our fit patients. To put a longer story short, these data are very promising. There is one study now published, combination of revumenib in combination with azacitidine and venetoclax, and their composite complete responses of about 80% have been reported, and CRs of approximately 60%. And if you compare that to historic data where we used only Ven/Aza, the complete remission rates were approximately 37% across genotypes. So that looks very promising. Some of these CRs were MRD negative, which add to the promise. At the same time, whether that really translates into increased survival, we still have to see. But back to your point, this promising phase 1 data has resulted in in a number of phase 3 label-enabling trials that have now been initiated, including 2 trials sponsored by HOVON, both using revumenib in the Ven/Aza combination and bleximenib in the combination with intensive chemotherapy. So we are very much hoping and that these menin inhibitors will move to upfront patients so that indeed as Scott was alluding to, perhaps up to 50% of our newly diagnosed AML patients can benefit from these agents.
So are there any other types of cancer that can benefit from these menin inhibitors?
Yeah, there's emerging evidence that the protein menin and therefore these menin inhibitors might have some activity in other types of solid tumors. Gastrointestinal stromal tumors, was actually a trial open with ziftomenib in that type of sarcoma. And in combination with some other agents, maybe there's a recently published paper on ER-positive breast cancer. I would say there's still plenty of work to be done to know what the real activity is in those diseases. We've known much more about menin for a long time in leukemia, so I think we still need to work through that, but early biological data suggests there's at least a possibility.
And if I may add, there is some interesting data here, Scott, as you know, in the the myeloproliferative neoplasms and preclinical data, but that are intriguing and exciting, where menin inhibitors have effect in preclinical models of myeloproliferative neoplasms. So that's another
Have you studied the effects of treating with these inhibitors just in any other tissue?
Yeah, so menin is expressed widely, and in fact, it's mutated in a hereditary form of cancer predisposition called multiple endocrine neoplasia type 1. So it clearly has other activities in cells throughout the body. To date, there hasn't been any obvious effect, but the inhibitors on other tissues, but certainly as more people take these, probably for longer periods of time, it will be important for all of us to keep a watch on what types of side effects might emerge. So acute side effects, not too much, but we'll see as patients take these for longer periods of time.
Yeah, I agree. That's an important point, especially because in these new trials, these label-enabling trials up front, we will be exposing patients to menin inhibitors for a longer period of time during induction chemotherapy, during consolidation, after allotransplant, and then into maintenance. So it is important to follow up. And in our ASH EHA joint symposium, we've addressed some of the preclinical data on the effects of menin inhibitors on other cells in the bone marrow than leukemic cells that may help shape both responses and activity, but perhaps also toxicity. So to add to that point.
Is there anything that you would like to add for the audience?
Yeah, I would just say that I think it's an exciting time that therapies that target so-called gene regulatory mechanisms are like menin inhibitors are really now making it into patients and seem to be making an impact. I'm hopeful that as we continue to learn how all of these mechanisms work, we may be able to come up with other drugs. And then, of course, I think all of our goal is to at some point, like what's the case for acute promyelocytic leukemia, actually get to the point where you don't have to use a chemotherapy. So when we'll get there, who knows? But at least there's hope that, that things are progressing.
I agree. What I would also like to add is, while we're moving into these targeted therapies and we're talking about smaller subsets of patients in a disease like AML, which is already a relatively rare disease, we need international collaboration. To be able to conduct these label-enabling trials in these small subsets of patients, it's important that we collaborate globally. And I'm quite proud that with HOVEL, in collaboration with the German AMLSG group and also the UK AML group, we've been able to establish trials where many national leukemia groups participate across the world. So in the US, in Europe, but also Japan, China, South Korea. And I think that is very exciting to see as well, that we see the scientific progress, but that we also succeed in bringing the world together to take these drugs towards patients. And I think that's worth mentioning.
So thank you very much to both of you for recording this podcast with us. And thank you to the audience for listening. If you enjoy this podcast, please like it and stay tuned for more episodes of EHA Unplugged.